Now, this talk will be on our cardiac blues work, really focus on chronic disease and mental health in terms of people with heart disease, because that's my area of specialty. So we're going to go through the cardiac blues, which is the work Barbara Murphy and I've been doing the last 4 or 5 years. What is it? Who gets it? What's, separating it from depression, and our cardiac blues project. So in terms of the cardiac blues, it's really about that emotional roller coaster, and that's what patients describe. Anxiety, fear, worry, anger, frustration, agitation, a sort of pretty natural response to what many patients see as a life-threatening diagnosis. It doesn't matter that many of our treatments and many of our interventions really improve mortality and morbidity. Patients in their mind still see heart disease as a death sentence and see it as a life-threatening moment. This is my mentor, Alan Goebel, from 1989. He was talking about this back then. It took a long time for the rest of the world to catch up. So as we know that 55,000 Australians have a heart attack each year, and we say a heart event is an emotional experience, not just a physical one. And that sort of gives people permission to grieve or to respond or to react. So when you're working with people who've got heart disease, especially after they've had a heart event, it's important to acknowledge that that can come as has an emotional impact. So we've been doing some resources, and the resources are really the sum total of our work over the last 20 years around what's normal adjustment. So this is one of our resources, and we call it normal emotional reactions to a heart event. Shock, denial, worry, guilt, anger, sadness, relief. So, and it's pretty. So the cardiac blues is these emotions, these responses, these emotional reactions, but also these symptoms. People commonly have a bit of a lack of interest in normal activities, withdraw, they'll get tearful. I run groups, for younger men after their first heart attack, men in their 30s, 40s and 50s. I call them my young ones. They love that. Even the 60-year-olds really like that. So I run groups, and all of this will be happening. All of the patients in the group will be talking about some of these: change in sex drive, confusion and forgetfulness, bad dreams and nightmares, worry about another heart event, and thoughts of death, thoughts of mortality. They have had their mortality challenged, and it leaves a scar on them. It impacts them, and I say to them, the first time that you have your mortality completely challenged is the hardest. After this, you assume that you are mortal. But until that moment, you think you're Superman. So who gets the cardiac blues? Our work's shown that almost all patients experience the cardiac blues, but that's separate to serious depression, which is around 20%. And that's also some of our work. We know what is depression, but when you look at this, you see many of the symptoms of the cardiac blues, don't you? Do you see that? And when you've got a physical illness, it can have a lot of psychological symptoms, symptoms that could overlap with depression. People change their appetite, they change their sleep patterns, they do get restless, they do have fatigue and loss of energy. Probably the one that they don't get as much in our cardiac patients is the feelings of guilt and worthlessness. But some of them do. Some have really strong guilt that they might have caused this heart event, or that they've let their family down, or they've let their workplace down, or that they can't look after the people they were looking after. So there's a lot of that. And the thoughts of death aren't, suicidal ideation. They are, I could have died and I might die and I am mortal. So what's important to know also in this context is that depression is a risk factor for the development of heart disease. Independent risk factor for development and progression, and that the strength of association is as strong as smoking. Does that surprise people? Similar magnitude of risk.
What does that mean?
It's all epidemiological talk. So, but it is. It's especially if you read this Bunker article and the Cahoon article. They're very interesting, and I can send that to you too, because they're probably the most important ones to read. So, in people with after a cardiac event, we've got about 20% will have major depression. In the community, about 5%. But what's interesting is over a lifetime, you'll have about 20% people will have at least one depressive episode. And it's almost like, you know, the cardiac event is the initiator, but it might have come along, you know, after something else or after a grief or whatever. We can't say that for certain. Now, there we know, it's important to know that we have effective treatments, and some of this is an article we wrote last year, year before, you know, CBT and problem-solving therapy are frontline treatment options to mitigate depression. But that's only for the ones with the depression, not for the cardiac blues. We don't have enough psychologists in Australia to address the cardiac blues in 55,000 patients each year. So, you know, our nurses are our front line. They are front line in terms of normalising this and supporting patients through this. So why does depression matter? It's associated with non-adherence. You'll know this, but you depressed patients after a heart event, got more dietary fat, more likely to smoke and less likely to be successful in giving up smoking, less physically active, less social support, and less likely to attend cardiac rehabilitation, which is your gold standard for supporting patients after a heart event. So if you've got someone with one of your first lines of intervention with someone who's had a heart event is to send them along to the local cardiac rehabilitation program. And that will, as they do their exercise and their education and learn their self-management, their mood usually improves quite rapidly. They get more confident, they know what they're doing, they're in control, they're not feeling so much as though they're a ticking time bomb. So depression is associated with non-adherence, and depression is also associated with increased morbidity. So predictors of 30-day readmission, depression, anxiety and living alone. It's after a heart event. It's a paper we did about 8 years ago. So people with depression are more likely to be readmitted to hospital, more likely to have a recurrent event in the next 12 months. And increased mortality. So depression, post-event depression predicts mortality 12 years later. So, and that's not just us talking about that. This is quite a lot of researchers for quite a lot of years. Nancy Fraser-Smith, who was one of our first to really bring the link between depression and mortality, she produced this graph in JAMA, and this has really started to drive attention in this area. You see the blue line is the depressed patients and the pink line is the non-depressed, and you see the curve going up. And you've got to remember this is an older paper, so this was data before some of our later interventions, but it just shows you how important treating depression is. And some of these are ours, the 12-year and the 15-year mortality. So depression predicts 1 year, depression post-event predicts 1 year, 5-year, 10-year, 12-year, 15-year. After 15 years, the relationship reduces, which is good. So the cardiac blues, common and normal, depression not. Depression is a problem that needs to be addressed. But our problem is that most of our people are seeing patients early on, and it's hard for them to distinguish between the symptoms of the cardiac blues and the symptoms of depression. And so therefore we need to distinguish that so we know where to put our resources, where to normalise. So we did some work around this, Barbara and I, and we've done a lot of trajectory work. By trajectories, it's looking at the pattern of change over time. So we've got various samples of patients that we've looked at: women, patients after an angioplasty, bypass patients, patients with heart failure, blah. Lots of different sort of patients who've had a heart event. And we track depression over time and where they travel. So this key message that we developed from this is that there's 4 typical trajectories of symptoms of depression. And I'll show you that. This is a very simplified graph, but I find it easy to explain. We've got our bottom ones here. And sorry about just using this one because I get really confused about having 2 screens. So in terms of our symptoms, this is your patients who have, we call resilient. You know, they get in the hospital, they're not depressed, they leave hospital, they're not depressed, they do their rehab, they say, oh, it's all right, I can get through this. So they're not showing any real signs and symptoms. These ones, they start low and increase. They're our delayed. You don't recognise them in hospital, you don't spot them in hospital. They're covering up their symptoms, but as you see, they're getting much worse over time. And then we have our recovered. You know, have really high symptomatology in hospital, reduces over time, and our chronic. So the chronic ones came in with depression, leave with depression. But our key message is that the cardiac blues is transient, so it's about time. This is 6 months here. Cardiac blues is transient, but depression is chronic and persistent for these patients. And what was really interesting is that the pattern, the trajectory, the pattern of depression actually predicted mortality 12 years on. So that's made this a very interesting paper. So if we look at the depression trajectories, and here we've got, this is in-hospital depression status and 2 months depression status. So some will have none in hospital, none 2 months. Some will have severe in hospital and severe 2 months. So, but here we've got the mortality data for these patients 12 years on. So, and what is really interesting is the patterns and the change across time. And for us, this one stood out, that the people who are worsening, who have worsening depression over time, the delayed recovery, have got the much higher death rate. And what else is very interesting is those who had high levels of emotional, high levels of symptomatology in hospital had low death rates 12 years later. So if they had low, they were recovering, they had low. So this is a very interesting paper. And it took us on a journey, this paper, around, because we know that what's most likely in hospital is that we will give attention and services to those who are showing the most emotions, because we're assuming that they are the most vulnerable. But what this tells us is this is actually somewhat protective, and it's the pattern of change over time that's important. So trajectories is one thing. So not, a lot of our guidelines have been up to recently just screen patients in hospital, and we're knowing now that it's screening not just in hospital but in general practice and in cardiac rehab, so we get a pattern and we know whether they're improving or getting worse over time. The other thing is the presence of red flags. This is our big Bendigo cardiac study, where we found that there were specific red flags that we could use to identify those patients at risk, which helps us to address services as well. So some of these won't surprise you. Some of these seem pretty what you would expect, but having them all together and having them as a bit of guidance is important. So in terms of patients who are living alone in social isolation, compounded loss, patients who just actually lost their partner or their job or whatever recently, So we've popped these onto this is our translational research work. We do the studies, we do, whether interviews or epidemiological studies or whatever, and then we find out what it is, what the symptoms are, but also what are the red flags, and we develop them so that patients can receive this information as well as health professionals. So this is our summary. Cardiac blues, transient, improving trajectory, not so many red flags, and good prognosis, whereas the same is not true for depression. The other work that we've done is, ask patients, well, do you want to know about this, and what have you been told? And this is just the end of last year, November, we got this one out. And basically, if we look at this graph, want information, 80%. They want information about the normal trajectories. Received information, that's a bit sad, isn't it? 25%. So a real mismatch. This is such a simple graph, but it tells us there's a real mismatch. And what they wanted was pamphlets and discussion with health professionals. Both were important. They just don't want a pamphlet thrown at them. So in summary, only 10% currently receive the information, maybe 20%. Most wanted to be informed, and most wanted written resources and discussion with a health professional. So this all informed our Cardiac Blues project, because then it tells us what we need to do to improve the services that our cardiac patients are getting. And we've got funded by this from funding from Beyond Blue, and they really went with us to really believe in this project along with us. Now, patients weren't receiving any information, so we thought we might do an audit of the cardiac wards. So we've audited 19 cardiac wards in Victoria, including some country and some city. And we had a really interesting response from those wards. Many of them told us were quite embarrassed about us coming to ask them what was going on, how they were addressing this. Some people had produced very poor quality resources that they felt embarrassed about, but that they gave out to patients, but they didn't want to show us. There was no coordinated procedures for informing patients about cardiac blues, about the normal emotional recovery, about the fact that there's emotional roller coaster. They were all informed about their medication. They all left hospital with an angina management plan. They all knew when to call the ambulance, but no coordinated procedure for informing about the cardiac blues, even though that would probably impact on whether or not they took their medication and whether or not they actually called an ambulance. No dedicated patient resources. We looked through all of their resources and, examined them with a microscope. Some of them, there was a paragraph on you might have an emotion or two, and some of them, there was nothing. And the other thing is that the staff, told us they wanted more knowledge and skills. They didn't feel like they were able to do this. They didn't know what to do. They felt like they weren't very good at it. So the audit reinforced the need for patient resources, but it also really reinforced the need for health professional training to make these conversations easier. So what Barb and I did is we developed and evaluated patient resources and the health professional training. So the resources, there's some resources out there on depression and heart disease, but they're very focused on pathology, and what we were interested in is more that normal process of emotional adjustment and processing that happens after a cardiac event for nearly all patients. So we looked at symptoms and signs of the cardiac blues, likely resolution. The good news is for most people, this goes, and that's patients want to hear that. If they're suffering emotional, and I have grown men who says, I've never had a mood in my life, and now I've got moods, and I'm crying, and I'm watching the news, and I'm feeling sad. And I just say, that's pretty normal. You're a bit more permeable. Your emotions are getting through. They were always there. They're just showing themselves to you, and they'll fade back down a bit, and they like to know that. Red flags for increased depression risk, and that's a bit of a self-assessment for patients to have a look at and say, am I at higher risk? And their family members look at that. And actions to be taken, just basic actions. And the aim to really normalise and reassure, but to educate about and to alert about the possibility of depression. So some of you might have seen some of these resources, and we've been asked to create some Aboriginal ones, and we're after more funding around this in the future. But this is our first ones off the rank, and we had a lot of focus group testing around these to really check out whether they were meeting patients' needs. The other thing some people may have seen is our cardiac blues health professional training. And really it's just, as you can see, there's those trajectories, there's information just to support health professionals around this. What was interesting is that we did some, because we're a research centre and do translational research, we can't help but measure everything, which means we get a paper from everything, which is quite nice. So this is when we got the health professionals to do our cardiac blues training, we measured their emotional adjustment support self-efficacy. It's a concept we made up ourselves because there wasn't much out there for emotional adjustment support self-efficacy. But what we asked health professionals is, how confident are you that you can recognise common signs of distress, can understand the common patterns of depression, can determine red flags, can recognise patients who are at higher risk of depression. But what I was most interested in is these last two, can discuss depression with patients and can discuss cardiac blues with patients. And all of these were a highly significant improvement over time. But it's interesting to look at the graphs. We can see that the pre is in the purple and the post is in the dark. See it in terms of recognise common signs of distress, that flowed up from nearly 3/4 of our health professionals were very confident at the end, which is how we want. If you think that we've got 50% of health professionals are somewhat or not very confident to recognise common signs of distress, that's a worry. In terms of the trajectories, a similar improvement over time. In terms of discussing emotional adjustment, this is lovely to see. It did my heart proud. We can see that prior to the training, which is only an hour training, it's not a major intervention, it's online training, it's very cheap intervention, and yet we get these responses in capacity and confidence to discuss depression with patients, with around 90% of health professionals becoming confident or very confident to discuss emotional adjustment. From prior to that, 40% somewhat confident. We were able to really move them up with a 1 hour intervention and discussing depression as well. So really it was about information and some modelling. We had some videos of nurses talking to patients and talking about the process. The other thing that we've been working on is what we call our ONTRACK Health Professional Guide, and this is under review at the moment. And we're thinking what people need is something to make it much simpler to know what to do when you get these patients with a chronic disease and with an acute emotional reaction to this chronic disease. And we call this our ONTRACK model. The first step is outline likely emotional responses and accompanying symptoms. That's really letting people know what might happen. Not that it will, I say it's not compulsory, but it may. N, normalise these emotions and symptoms. So normalising is a very powerful intervention. Talk to the patients about their emotions and symptoms and reassure that they're likely to resolve. We know that if 90% of patients get the cardiac blues and 20% get ongoing depression, for most of them it is likely to resolve. Alert patients to potential risks, i.e. that's around the red flags, It's around that if your pattern doesn't improve, if your mood doesn't lift, check that patient has strategies for dealing with emotions and know your referral options. So that's something that we see makes a lot of sense and makes it somewhat easier. Do people think that that's a useful, yeah? And you can contact, these are on the Heart Research Centre website. These are available to download for people. We've got a much longer resource, which has got a page for each of these, and but because I get a bit short attention span, I've decided we needed this. And anyway, so this is the detailed ONTRACK research information. So that's available. So in terms of our resource dissemination, because we go from the research, the basic research, to developing the resources, to pilot testing the resources, to checking, if the intervention's working, and then we disseminated to the cardiac rehab programs, coronary care units, cardiothoracic units, and Medicare locals, as they were then. And there's a separate phase for further dissemination. But as part of this dissemination, following the dissemination, all of those 660 resources, and that included the online training, access to online training, and a resource pack. So what we found, and this paper's just got accepted yesterday, which is lovely, the British Journal of Cardiac Nursing. So that when we did a survey of a subsample of these, 93% had heard of the cardiac blues, 90% discussed with patients, and 75% discussed the cardiac blues with all patients, which is a really big shift. 58% offered the brochure on the cardiac blues. So, and we also, in that paper, we looked at some of the barriers, so that can inform us in our next stage of where we're working. We also last year, as part of raising awareness here, we held our first ever Cardiac Blues Awareness Day, and we featured on the Health Report and various other local and national media events, which was great. Distributed information and resources to patients and families, and this was the buy-in we got from hospitals across the country. We got 50 hospitals running events, and just part of this was the health professionals themselves, starting to say to the hospital, no, this is where I'm going. I'm interested in mental health and chronic disease, and it really flagged. Many of these hospitals did a little bit of write-up in their newsletter. So this is one way of really raising awareness from what we had was a very low bar in terms of awareness. So our key message for that Cardiac Blues Awareness Day was a heart event is an emotional experience, not just a physical one. Cardiac blues is common and normal, but it is distressing. Depression is less common and a poor prognosis. Health professionals need to know the difference. But health professionals also, our frontline health professionals need to be able to prepare patients for this emotional journey, but also to be able to flag if they're at risk of ongoing depression. And we even, we had a animator worked with us and developed, if you look up on YouTube, you'll see Cardiac Blues on YouTube, and he's a lovely animator, and he did the blues, and he did it really well. And the dog even got the blues, and then it all passed. So it's just really trying to think of ways to reach your audience in many, many ways. So, whether it's a social media, whether it's, mail outs, whether it's whatever. I want to acknowledge particularly Bella and others from Beyond Blue who really believed in this project from the start and have provided some really good ongoing support. People from the various hospitals, funding bodies, all our early adopters, and we love early adopters, people who really come up and say, yep, I'm going to run training on this and no one else has ever heard of this. So it's really, you've got to really acknowledge and reward those early adopters, because they take the rest of your team along. And some of our academic leads and some of the ones, like Jeff Waters, who'd had a cardiac event, who was ready to front he's from 7:30 report, and Andrew Pike from Ronan Film, who'd also had a cardiac event and suffered a lot of depression. He's currently doing a film on our cardiac blues, so really raising awareness in different ways. And Neil from Boeing Production, who's our animator and very enthusiastic artist, the creative man on the team, and the whole of the cardiac blues team. So I'd just like to, I'll leave it there. Thank you. We've got time, so much questions. Yeah, that's good.
We've got a bit of time before the next presenter, so I thought maybe there might be some questions in the audience. Yes, Julie's got a question.
Thanks for the presentation, it's great. One of the things, I've worked as a mental health nurse consultant in General Hospital for many years, and one of the things that I find absolutely intriguing is that despite all those figures that are, that are so clear that if we, recognise depression in people who have had a cardiac event, outcomes are better. Cardiology is one of the worst referrers to our mental health service.
Don't you hate that?
And I find that absolutely astounding. So my question is, did many cardiologists take part in that training program?
No, it's they were very busy. Yeah, they've got a lot of interventions to do, and they're very busy. Okay, you don't want to interrupt your cardiologist when they're. We've got other ways where we reach our cardiologists, and it's a slow process. And my mentor, Dr. Alan Goebel, said sometimes you have to wait for people to die to get change. That was a bit miserable, wasn't he? But basically, it's getting up there. We've got some of the key movers and shakers in the world of cardiology wrote the last position statement on depression. We're getting there. We're getting people out there talking about it. It's getting more airplay at the conferences. We did a couple of webinars on this. And so we are getting out there, and we're getting our change champions there. So don't be too depressed. They don't refer that much to cardiac rehabilitation either. So we have to have other ways of, and probably general practice is our way in, and good links with cardiac rehabilitation programs and mental health services, because they need the support. Cardiac rehab programs don't feel very well resourced to be able to address depression needs in their patients. They're really thinking, many of the people working in cardiac rehab are thinking acute care.
You have any more questions?
Just a couple of things, and mainly from being involved with this from my husband's perspective. One of the issues was that for my husband having his surgery was that he had a stent the year before, and the interventionist had said, you won't have a problem now for years. And so then he had, within 3 years he had his bypassing. And so he was absolutely devastated. So that was one of the issues. The other issue is from a carer's point of view. I'm a registered nurse. I've worked for 30 odd years in nursing and whatever else, and I still have flashback nightmares about my husband being on bypass.
Yeah.
And it is the most, and I don't know, there's not a lot of support to actually acknowledge for those people who are, I know we're struggling with patients, but carers, it's a really big issue.
We've just finished a research project in this area, and we're really wanting to drive an online community for carers to provide that sort of support. So that's a future project. And you're right, patients get told they're fixed. They get told, they don't get told you have a chronic disease that's going to have need ongoing attention for many years, and you'll have to take your medication for life. they're told, oh, we fixed that blockage. So yeah, and it is a shock for people who think that they've had just something very minor, and then if they have a bypass, it sort of like hits them then. Yeah.
Okay, well, thank you very much.